don't think we have a quorum. So. Do we have a quorum?
I was asking.
What is the,
You have 2 out of 3?
2 or 3.
Are you 2 on the committee?
We have 2.
I'm on the committee.
Isn't Kenny counted too? Do we count Kenny?
Well, you only need 2 committee members, so if you were both on there.
Okay, so then we could approve the minutes if somebody would.
I didn't get a packet. Did I miss something? It was not in my
I'm looking at mine.
There's-
Microsoft Outlook. I usually get that out.
It's in Microsoft SharePoint, in SharePoint. You should have gotten an email.
Okay,
With the
in
link.
August?
Okay.
Making sure I got that in again.
I didn't send,
What?
it's in SharePoint.
They've been walking over here. So,
Clients.
is yours thankful?
Yes, it's not but left.
I'll talk to your admin assistant.
you know what I did? That's not, I apologize. I'm going to move to approve the minutes because they've all been very, very accurate and I trust that Hal read every word.
There.
I didn't look at them as carefully as I sometimes do, but I looked at them. So I guess in the absence of anyone else, can I second? There are parliamentarians like me second me, then without objection, we'll consider them approved. Okay, let's see. Well, actually, we're getting ahead of ourselves. We'll call to order. We'll call to order. Roll call.
I've got it.
How about the agenda?
Move to approve the agenda.
Okay, so without objection, we'll consider that approved. So the approval of the minutes is not allowed work, but we'll consider that. Close enough. Public participation, I think you told me nobody from the public is on.
Everybody's online.
Okay, so a new whole business compliance dashboard. Well, let's see. I'll ask a question about this.
Okay.
So I noticed in the internal audits, there were, in the first quarter, there was a large number of claims reviewed and then a smaller number, but it was the internal monitoring where there was a smaller number of claims reviewed and a smaller amount of money returned. What's the difference between the audits and the monitoring? I don't think I understood that difference. I'm on the last page, right before he gets into definitions. Yep, right up from the bottom. So number of claims reviewed by the audit committee, 45 in the first quarter and 20 in the next. And then down below, discovered by internal monitoring.
So this comes from Tammy.
It's nice, Tammy's, if she scraps claims, it finds.
And what's the difference between internal auditing and internal monitoring?
So internal monitoring is just our day-to-day process. Internal audit is where we say, hey, we're gonna look at PT claims, we're gonna go front to back,
ET.
physical therapy.
Oh,
So that was one I don't know if we did a physical therapy, but an audit is a formal process where we look at, it's registered, it's from the order. It means it goes through like prior authorization, we look at registration, we look at HIM, we look at the whole revenue cycle through an audit process and see if there's any claims we have to repay.
Right.
So it's a more inclusive process. Internal monitoring is Tammy's just going through claim scrubbing, looking at payments, finding issues within that process. That's just an internal process. So
in issues to the tune of a couple $100,000.
it could be. So typically, I mean, if she goes through and she's finding a pharmaceutical issue, like the multiplier or the multiplier on the number of drugs is wrong on a certain set, she runs the claims to see if it's wrong and anyone that paid, and then we correct those claims. And that's how usually it goes.
And this is something that actually Joe and I have had conversations with, because in his last hospital, he had a more formal process for audits. And that's something that we have talked about maybe changing up here, of having a more formal audit process and using maybe an external auditor to look at for claims.
But the same people are doing the internal audit,
Mhm.
just
Yeah.
a different
Yeah.
protocol.
Process.
And right now they're getting ready for rack. So they're, that is, they're looking at, we have to do, looking at a lot of claims for, we have a request for external. So they're really ramping up and looking at all the claims that we have to look at right now. So we're not doing as much internal monitoring ourselves. We're looking at doing that external review.
The Medicaid audit, is that what you're referring to?
Yes.
Yeah.
Okay, then the other question that I asked Nathan in the past is it, so here's the numbers. Is there anything that we should know behind the numbers?
For me, when I look at the numbers and I talk to it, I think we should take more data from what we look at it to look at our documentation. So this is the one thing whenever I sit in on these meetings is, and this is the one thing that Joe talks about is his last hospital, when they had auditors come in, they focus more on education. So when you do an audit and you have a payback, why did we pay back? So that is the one thing that is in the report moving forward is if we have a payback, why? And then we do education for, is it physician documentation or PT documentation and that, so that way we're not continuing to have paybacks. You know, and that's why I think it's really important to do the why of the paybacks and provide education, because the physician's going to continue documenting and doing what they are doing until someone says, you know, you need to either document this way or make small changes in how you're doing it.
I thought case management did that.
That is CDI, which is a little bit different. That's in real time of trying to be proactive and looking at it. This is retrospective.
Okay,
The audits will be, it's not just physician orders, obviously, they look at the whole process. and
Yes.
they go through these things. And then we should treat it like a joint commission audit, where if there's findings, we come up with remediation, follow up, and then we audit after a certain period, make sure you corrected the issue.
Right.
So it's trying to align this process with how we do the joint commission, I think.
Yeah.
We're looking to.
Yeah, because some of it's like our physical therapists, are they documenting correctly, or speech therapists or diagnostic imaging? I mean, it's not just physicians.
Joint commission does not go into that much detail though, in general.
They don't, when it's more just mimicking the
Self-policing.
process. Yeah.
Yes.
Just taking the
And they
process.
will do a sort of a slice here and
Yeah.
there and look at it. Okay, that's what I thought.
Yeah.
And then RAC is a self-reporting that is for physicians as well. I forgot what the acronym stands for, but you have to essentially police yourself, look at your claims, make sure a 99203 fits what you were reimbursed, and then you're going to be penalized based upon your total claim.
Right. Yeah. And now they have basically people coming in and auditing like for Medicare and that, and they get a percentage.
Of what they find.
Yeah. So we have to do the best we can because they'll audit so many charts, and if they, like the last one, they found what, 8 charts or 10 charts
Oh, yeah.
that they found a deficit, and then they say, okay, we found errors on this many charts, and now we're going to extrapolate over the course of how many we have, and now that's your total payback. So
when they do that, how do they select the charts that they get access to?
It's supposed to be right.
But random.
We know they have scrubbers in the backside that look for patterns.
Yeah.
And they'll pick off.
yeah,
Random use Coloco.
right.
We know it's that. When usually it's like the biggest claims.
Yeah.
The biggest claims are where they've had benefit before.
Exactly.
But it is random. It's really random, that extrapolation, expansion. makes sense. But if it's not random, then that doesn't make sense.
A lot of things don't make sense. Sorry, when it's the government and.
Yeah. Okay, so
Yeah.
That's a good point.
any other questions from members of staff? Okay, should we move on to new business? This is what I'm eager to hear about, I think, the Joint Commission survey report.
So I'll just, before I turn it over to Rhonda, I just want to say that this was in the holiday meeting, but since that was postponed, I moved it to compliance because compliance also oversees regulatory oversight. And I thought it was beneficial for the board to have this moved through on a more timely basis because I didn't know when I would get a new chair of the quality committee. Thank you, Dr. Rester. Or when the meeting would have. So that's why I asked Rhonda to provide this high-level summary of the Joint Commission report and have it come up through compliance. So I moved it from the quality committee to the compliance committee.
And this is actually really, really broad. If you are interested in seeing the actual in-depth report, please, I can share that with you guys. The major thing to take away from this is that the majority of our 42 citations had to do mostly with life safety and environmental care factors. When they talk about life safety, that is mostly like building related things that makes the environment safe for patient care. Things like the doors to the OR. You know, like infection control is a big area. Well, we have cleaned the doors enough where a little bit of the finish was coming off a section of the door. That was one citation. So another door from the OR had like some scratches and gouges in it. So that's gonna be another citation. That wasn't another citation. And it just will be kind of like, we're gonna paint it, clean it up. We don't need to replace the doors or anything like that. Another example of like a life safety environmental care item had to do with our people that come in and inspect our emergency signs, our strobe lights, our fire dampeners and such. And they had put on their report that the reference that they used was the 2018 manual of the NPFA guidelines, like National Public Fire Administration guidelines. Well, CMS uses the 2012 version of that reference manual. So we are in the process of trying to get documentation saying like everything that's in the 2012 manual is in the 2018 manual or a higher standard. You know, so just, but there's nothing we can do about what they put on their report. The other, some of the other issues were competency checklist for nurses, behavioral health aides, therapists over at BOPS. Our competencies are kind of, and I'm saying this because Chad's here too, they are spread in so many different areas and each department had their own little style of doing it. They weren't standardized. So we had trouble finding the ones from the behavioral outpatient clinic.
Excuse me, when you talk about competency, are you talking about the competencies or you're talking about documenting?
Documenting competencies, yeah. So so we're doing a standardization process where everything's going to be kept in one location in our Relias education tracking system. The other,
Can I interrupt?
Yeah.
Is that, I assume that's not medical staff, that's general hospital staff.
general hospital staff, but actually, and I didn't realize that even the office manager of the Bartlett outpatient clinic needs to have competency. So that would probably be like, what her competency would probably be like in HIPAA, you know, like in maybe mitigation of suicide risks, you know, like factors or, so that actually needs to be created because we really don't have a competency for the office manager over there. And I never even thought of that aspect, but, so that's, will be like completed and taken care of, and it will be better for going forward. And it's actually something that we needed to do, so that just highlighted something that we knew we needed to tighten up on, and we will do it. The other couple findings has to do with just, we got cited for like expired Oxivir cleaning wipes. They expired at the end of August. They came September 17th. Bags of IV fluids that are not like most commonly used IV fluids. Expired August 31st. Once again, they came, and those are all separate, little separate things, but the Joint Commission actually overall said we really had a pretty good survey, and they were happy to see the hospital as clean as it was, people doing hand sanitizing, quick to respond to questions of what do you do for patient safety? Like all the staff on all the floors and all the areas responded readily with great answers. And the Joint Commission, when they first came here, we had to share with them a little background of what our organization is in the process of doing and changing. So they had some knowledge of the ongoing processes with different services being closed and rearrangement and different positions being changed over. But they could not, they made the comment that if they didn't know about that in advance, they would not have been able to tell that based on the patient care and the level of staffing that they saw. So that was good to hear. If you have any questions or anything specific, I would be happy to share specific items with you guys.
So are the 42 listed anywhere? I've never,
I got the list of the 42. If you would like to see it, I can ask.
I'd like to see it too.
Yeah. Yeah, Rhonda's, her office is in the quality office, so feel free to pop in and visit with her. She can share the report with you and go through.
And I can actually email it.
yeah, if you want to just email me.
Yeah, that's fine.
And then, and new this year, this is the first year that Joint Commission is auditing hospitals. And they are being audited on how well they audit hospitals according to CMS conditions of participation and CMS standards. So we do have an engineer coming back in between October 20th and November 4th. Since we had so many different little life safety, environmental care issues like the oxygen tanks out back of the loading dock, that has to be more secured, and things to do with the building and things that Mark Walker is working very hard on getting completed. But we have enough of those to necessitate an engineer coming back for one day, like to re-inspect. And that has to do with the CMS condition of participation standard that we have enough citations.
Will that be an unannounced?
Yes.
Yeah.
And then through the chair, we use Joint Commission for deemed status for CMS. So
Commission for deemed?
deemed status. So for CMS, for our CMS status, we have to have a survey done by CMS, and we choose to use the Joint Commission because they are one of the organizations who can come in to survey us rather than having CMS directly. So they are a deemed surveyor.
Oh, deemed. I thought you were using an acronym.
Deemed.
Oh, okay, all right.
DEM,
Yeah.
DEMP. So if we were in the lower 48 and it wasn't so expensive to travel here, we probably would have had a CMS surveyor and a Joint Commission surveyor at the same time simultaneously in our organization. But because we're in Juneau and it's still the summer season and it's very expensive to travel here, CMS did not send a surveyor to validate the Joint Commission survey, which was yes. The surveyor that Catherine, the lead surveyor, was the same surveyor that came 3 years ago. So she knew our hospital very well. And she is also a surveyor who is certified to do initial and ongoing surveys for hospitals who transition to critical access. So it may or may not be that we get to see this surveyor again in a very short time.
A year. Good question. Two parts. One, I have seen the list of 42. What would be the most expensive? And what would be the most problematic from a perhaps?
The most
safety-
problematic is probably the documentation issues at the Bartlett Outpatient Psychiatric area. With the Meditech version over there, we haven't really had good templates created and consistent staffing to learn Meditech appropriately. So
something.
and we're working on that, and so that they had 6 citations alone at the BOPS. So
And through the chair, they came right before Rainforest was closed. So that we had a behavioral health surveyor who spent a lot of time at BOPS because she didn't have to spend much time at Rainforest because it was closing in 3 days. So she spent the majority of her time at BOPS and did a very deep dive into that location, which is good for us because now we'll be able to really fine tune that location.
So I assume that's the most expensive then, because we'll have to hire somebody to set these forward.
we have informatics is going through some changes and everything. And we currently made it a priority to have one of the informaticists that actually might be leaving, prioritize her time, to kind of like get some of these templates up and going, to make it easy for compliance, to make them document all the required screenings that they have to do. So hopefully it will not require like a separate expense.
Yeah, I think it's just labor cost,
Yeah.
which we're already paying, just redirecting those hours.
That's okay.
And then some of the environmental care issues, Mark might have some expenses as far as building repairs and things like that, but I don't know what costs.
It definitely won't be as expensive as they were 3 years ago when they had to redo all the behavioral health, mental health unit upstairs. Should be fairly-
Yeah, overall, and the majority of those are already corrected. Like, I'm gonna say like a quarter of them were corrected right after the surveyor cited them. They were able to get them corrected. 3 of the citations in the environmental care had to do with unapproved power strips that were all over the place, door wedges, which is like a no-no. And we're gonna take Joe's recommendation from my prior hospital of tethering the door wedges to the environmental services carts so that they can't be put in a door and then left unattended.
So they pull the car away.
And then ceiling tiles, kind of like if you see a stained ceiling tile, or you see a ceiling tile where IT came in and maybe has a wire coming from their Wi-Fi device or something through the ceiling tile and it leaves more than 1/8 of an inch gap. That is a citation. And they were just here doing a project. So it was like numerous spots.
Thank God they got the fruit fly situation remedied in the operating room. A couple years ago, Gail, I don't know if you remember that.
Yes, I do.
Fruit flies.
Yeah, no, all our room at work.
Yes.
Not an issue now.
Yeah.
Sorry.
Oh,
Yeah.
we did.
This is an old fruit fly geneticist. And wondered how did that? I'm curious about fruit.
We should have called you in.
Goes off a little, I think that's good.
Possibility to get a source of protein in here or something.
Oh, there's like 4,000 possibilities.
There was a piece of food that was left up in a ceiling tile that was from a repairman.
Yes.
Source whatever.
Yes.
Are you serious?
Yeah,
At
well,
least it
another,
wasn't the whole repairman.
yeah, and another citation is like when they do their, like their data wires up above the ceiling, if they're laying on like a sprinkler pipe or piping, that's a citation. So
Supervision.
IT is actually gonna be helping out facilities, trying to find all these little spots where an IT person was that might have left an issue. But I'll actually have copies of the report ready for you guys to take if you want to.
Yeah, that'll be good.
Anything
Okay.
else I can
Any
answer?
Any
or-
questions from staff? Any other questions? Well, thank you. Thank you, Ron.
You're welcome.
Thank you, Rhonda. Excellent job.
Thank you.
Okay, critical access. Tell me more.
All right. So, so I thought this would be a good education session to go into for compliance. Because for twofold. Number one, we are moving forward with critical access. I want to say Joe has been doing an amazing job with working with the state on it. And number two, part of moving forward with critical access is there's a large education part of critical access that we have to educate our staff, we have to educate our community, and we do have to do board education also. So I wanted to make sure that Erin is building out a web page that will be going live soon for the community. We have been doing a lot on our staff, but I also wanted to start providing some education at board level. And I thought having a little bit of a summary of what's going to be happening with the compliance side will tie in really good with what we just went through with Joint Commission. So I just wanted to give you a really broad overview of where our next steps are going. So right now, Joe has been meeting with our state on getting our variance. So I just wanted to give you a heads up of where we are and where did you go? All right. So this is kind of a background of what critical access, the rules of why we have critical access. I know how you are big on where to find the regulations, so you can go back and look at it of where it came from. So originally it started in lower 48 in Montana. If you want to look at the conditions of participation, the COPs on it in the federal regulations, it's in the 42 CFR part 485 subpart F. It has a nice real limited section. You can move forward, Anita, of where all the regulations are. Basically, we fit into the little cost section of critical access. We are rural designated. We are a drive away from any other hospital, if you call us a drive. They originally had critical access hospitals as only 15 beds, and then you could have swing beds or 25 beds. They had changed that now, so you can have up to 25 beds. Critical access hospitals need to have 24-hour emergency care services, which we have. And then our average length of stay should be about 96 hours per patient for our acute care patients. So we fit all of those criteria for a critical care access hospital. Yes.
Except the 96 hours.
We're
We're
working,
getting there.
we're working on that. We have never really focused in on that. So that is something that we're gonna have to be laser focused in on our length of stays. And we can utilize our observation beds. So that will be something that we're going to be doing a lot of education with our med staff, with our case management.
Swing beds too.
Yeah, swing bags, wildflower.
As well, yeah. Swing beds would be used as a step between us and Wildflower
Yes.
Works. Basically, we're providing the same service under that.
Yes.
But it takes them out of the, like, the stay equation.
And just to educate how, or inform rather, case management, we've got an amazing case management team, and they're always hounding the physicians for documentation. So
Yeah.
I suspect when they say they're going to focus on this.
Yes. Yep.
So this is average. So somebody comes in with, well, pick something that's going to take more than a week.
Mhm.
As long as that's offset by several people who are just here for a day or so. we're good.
Yes.
So
And
if we look at, sorry,
go
we
ahead.
looked at the last, I think Jim looked at the last 12 months, we took the top 10 outliers out of the equation, we beat this.
Yes.
This the management of those outlier patients. As well as just the day-to-day, so keep everyone.
And I know, I think I've asked this before and it was answered, but it didn't stick in my head. What do we go over that? Can we get a very?
So this particular, if we go over this, it becomes a joint commission finding. They find it during survey.
And then
But is there a way to get forgiveness?
you just do like you have a survey and you have a finding, you have to have a plan of correction.
But is there some way to say, well, we've got this one patient who's got burns or
Yeah.
something? Can we get permission to take him out of the equation before we do the calculation?
We either can put them into a swing bed or we could put them into a respite bed. There's other options.
It's the management of the patient, where they're at is what we gotta do on our side.
Mhm.
And so patients that require, we get patients that are kind of in between us and Wildflower Court. Like we had a patient that required wound back. It's something that can be handled and they kept it here because they couldn't handle the patient. That'd be the perfect example of someone that you move into swing because they meet the skilled need, but just not something Wildflower Court would be.
Well, I'm thinking more about the patient that might send off.
We want to request a variance on a single patient from
Right.
CMS. That'd be something that we just have to deal with.
And they look at consistency, if we're consistently
Yeah, if you bring it over,
over consistently that, then they start
I'm not
thinking.
concerned about
Right.
a single unusual patient.
they're more hardline on that. Have you exceeded 25 inpatients? The 25 inpatient beds is more of a hardline rule that they send the CMS review. So that's when we get.
And could I ask, why are these things, these rules? What's the point of 25?
Arbitrary number from my perspective. They just picked it out of there.
It's also a function of size. If a big hospital tries to get this designation because the income is so much greater, which is why we're doing it.
Yeah.
So there has to be a number.
We had to limit it. And so it started at 15 and it's went up to 25. So potentially we go higher, I guess.
Because of these small, again, from the 30,000 foot view nationally, many of these small hospitals are closing.
Yeah.
It's creating hardship in certain counties in the country.
Okay, next slide. So here's the process. Right now, Joe has been working with the state for variance population and currently under review. He's been working on that. And then we do our application. And so we will be doing our application for the hospital, and then we're also applying for a distinct part, which is our MHU. So we'll have our hospital, which will have our inpatient, which is 25 beds. We'll talk about what services we are continuing, which is all of our outpatient services, our emergency room. We're still going to have deliveries. We're still going to have PT, OT, speech, all of our service lines. We're not cutting anything back on that. So that's what will be in our application. And we're going to have a distinct part of MHU. And once we apply for that, then we will have an unannounced survey by CMS. And because we are continuing with Joint Commission, they can say Joint Commission do an unannounced survey. And we will have a full survey, just like we were a brand new entity. So it's not a 3-year one. So this is a nut and bolts from like we were a brand new entity starting. So we just had a practice survey is what I look at it. So I'm glad we went through that. And then if we have any deficiencies, we'll have to do a plan of correction and submit that to CMS. They'll have to approve that. And once they approve that, then we will be approved to start billing for Medicare.
We get an update on the meeting with the state.
Yes, you may.
So when we met with the Department of Health, there was particular focus on services and whether this move to critical access would be a move to close additional services. So in the state of Alaska, there's 2 different ways you can be in critical access. You can do it under a current license and just change the bed count to 25, which is probably the way we're gonna go, or you can actually get a license as a critical access hospital. And so with that, it makes some of our core services optional. The biggest one being obstetrics. So that becomes an optional service we would be required to offer under that licensure. It would also impact the way Medicaid pays us from a critical access standpoint. Then we would go out of the APR DRG system back to the cost-based system. With that being said, it's only worth $97,000 at this point. And I'm afraid if we go with that application, it's going to stall because the state is concerned about us closing additional services. So if we want this to move forward, I think we have to move letter.
Yeah. That was the plan.
That was the plan. And so they just brought these up. We had lots of conversations about the services, how we do core versus non-core, where our plans were moving forward. It was just, I think that was my takeaway of the meeting. They want to make sure we're not using this as a way to close additional services. They had questions about that. They also talked a lot about mental health. There's still some concerns about needs in the community. I know Kim was able to talk with Heidi Hedberg afterwards about what we're doing with PES and mobile integrated health.
Mobile crisis.
Yeah, so that's kind of all right. And so they had sent us a letter. We're going through that full, giving the information they requested back to them. And they've supplied us with additional information for consideration around the licensure, around laws that maybe we didn't consider, I guess, and the need for a community health needs assessment, which I'm still questioning whether that's required or not. So community health needs assessment just is it's that big survey, what's in the community, what people see as the gaps of care from the patient's perspective. And then the law they cited was the 501R, which goes back to 501c3 status for nonprofit hospitals, which we are not.
So that'd be a survey of the general population?
Yeah, which I know the city's been engaged in one with multiple different entities. I think there's 10 people involved in that, if I remember right.
And we're actually involved in that.
Yeah, so that's currently ongoing. We should have that next year for next spring.
Yeah. That's fine.
I suspect that will be a non-issue because if you survey our population, it's generally specialty care that is the problem, not will be nationally. A lot of hospitals are closing, will be Petersburg isn't doing great before a lot of hospitals don't. That's not an issue here. We have robust OPs for. So this all should be a non-issue. Survey should be a non-issue.
It should be. I mean, things I expect going up would be housing, kind of social determinants of health. Seem to be what some of these surveys now. So
And we need neurology and orthopedics. These are not part of a critical aspects designation.
it doesn't touch the hospital. So that's kind of a quick update.
So when you talked about this before, it sounded like this was a bit adversarial with the state, but that they calmed down.
It started that way. I mean, it definitely started that way. By the end of the meeting, it was more relaxed. We're just having regular conversations. So as they understood where we were coming from, I think they relaxed in the meeting. It was much more just conversational than accusational, I guess.
Yeah.
I know that this changes our federal income, but what's the cost to the state? Does the state,
If we don't change licensure, there's no cost.
there's no cost to say, okay, because, I can just see Governor, saying, well, we don't want that to happen because it'll cost us more.
Yeah,
That's not the issue.
it's not an issue. So they have no skin in the game from a cost standpoint.
Okay, thanks.
Next slide. This is just information, MTALA advanced directives still apply to us. And then next slide is just about what a swing bed is. So you hear a lot about swing beds. Swing bed is basically a reimbursement term. So if we can either apply with or without swing beds. And a swing bed is an approval process that only CMS can give. State doesn't have anything to do with this. CMS gives us approval to participate in their swing bed program. And we can determine, Joe determines whether he wants to have swing beds or not. It's included in our 25 bed cap. So we decide as a hospital if we want to have swing beds. You know, if we are having issues with getting people out, like, you know, long term, you know, maybe it's beneficial to have a few people, you know, that we can put in a swing bed status. There are some benefits. It doesn't restrict to the length of stay. There's also the requirements of they don't have to go to a nursing home or a transfer agreement. You can discharge them to home. So there are some good things that happen with swing beds. There's the 3-day qualification stays on it that you are required if you're sending them to a other location for the same treatment and that. So there are some benefits of swing bed patients.
And the 3-day applies both, doesn't matter. It applies to our situation.
Right.
What is the 3-day qualification stay? What exactly?
So if you're going to Wildflower Court, you have to have a 3-day qualifying stay at a facility, because if you don't have that, then you're at Wildflower Court, that affects your
Their
payment there.
reimbursement.
Mhm.
Where is the patient getting this qualifying?
Here,
Acute care hospital.
yes,
Okay, I see.
yes. So, and because we own Wildflower Court, we have to be mindful of their reimbursement. Yes.
So
Because
I
ultimately,
can't just go, if I were to have a stroke, I can't just go to one.
right, so if you were here one day and then you want to, we can't immediately send you there after one day here because, well, we could, but then it would affect your reimbursement there.
We run into this problem a lot from a case management perspective, where someone comes in and require skilled care, but like medically they're ready for discharge after day one.
Mhm.
And so, I mean, it's something I think we faced in the past too. It's just a problem in the system. They had waived this provision during COVID in a way to get people out of the hospital faster. So I know they're looking at it from a federal level too, whether it still makes sense long term. I mean, if your goal is to move them from expensive care, which is a hospital setting, to a less expensive, I mean, you want to expedite that process.
Yeah.
So I think they would be.
And when you do your subacute rehab, it is reimbursed by Medicare. So that's where the money falls. So that's where you need your 3-day. And then distinct part unit, this is our mental health unit. So this actually, if you are bored and you want to go into the conditions of participation, you will find the distinct part unit under the hospital section on it. So the distinct part unit doesn't have to be a separate building. It can be a wing, it can be a floor, a hallway, but it just needs to be certified as a distinct part unit. And it will be surveyed under the hospital rules of the condition of participation. And our mental health unit would qualify for that. They still can use some of the therapies that we have. So we could have our physical therapy go up and provide services. If we had nutrition services, so we can provide other services to that distinct part unit and get reimbursement on it. The only thing have you gotten any feedback on whether we can have offsets or not? Observation.
I've never heard anything. I mean, the Joint Commission, our surveyor stated if we were able to put doors around those and clearly identify them as outpatient, we could keep 2 beds as observation there. Which is
So, and I'm just getting, so the benefit is that that does not fall out to our 25. So you're
Correct.
able to cleave off by
Yes.
policy certain parts of your hospital to stay at the 25 limit. That's really
Only
nice.
two different types. So you can have a rehab or a mental health are the two distinct part units under condition of
So we still
participation.
get the income, doesn't count as our 25 cap.
Yeah.
Okay, got it.
Yeah, so with critical access, it is limited to 10 beds that can be used as.
That's easy for us.
Yes.
Yeah, and we looked at it with, we looked at a 6-month period, we passed that one time.
Mhm,
We seemed to waver somewhere between 8 and 10, so it's.
mhm. So right now we have 12 beds up there. So that's what we're, Joe and Kim are working on, whether we can have 2 beds as observation beds to help with the flow through the emergency room. Have 2 observation mental health beds. So that's the one thing. Okay, any other questions on the regulation side of critical access?
No, thank you.
Just a comment, what we just do shoehorn in there, don't we? I mean, it's just amazing how we just are right at 25, just at 10 with 2. Like it, right at the edge, but we can do it and it'll help our bottom line substantially financially.
And so we looked at this from a size perspective. So you pulled data on what a big critical access hospital is. And so I think we would be one of the bigger ones, but they're much bigger critical access. And that's from a patient data perspective. Some of these managed, they almost cap out 25 every day when you look at their discharges and their average length of stay. You know, so we fit nicely into that perspective.
It must be easier to do with better road system.
Yeah, if you have a mechanism, like if you had multiple nursing homes or other mechanisms for discharging patients, which we have now, we welfare court, we have home health and hospice. So we have kind of some discharge mechanisms. There has, I guess we'll have to continue to watch the mental health. We get people that continually push into our 25, if we have to hold them on medical versus on the MHU. So,
Which is why we've got to get the people taking the rainforest up in the roadway.
which I think they already looked at the first 2 patients, right?
Yeah, they've already taken two patients already in the community. That was 3.5 services. That was last week.
Do they have, it was, when I came here, I asked questions about how effective was rainforest recovery. Nobody really knows. People just got put in and they did the best they could and out they went. Do we have any way to tell how effective they are going to be?
I can ask them, I don't know what they track. I'm not sure what they track. Citizen rates or. how they manage that.
They're high.
They're high,
They're high, yeah.
unrecidivable. Yeah, well, pretty much
Nationally.
all programs. But I'm surprised there's not more curiosity about effectiveness. Yeah.
Same.
I think their concern, or some of the concerns when we've kind of mentioned that in the past has been, they don't want like grant programs and stuff like that to look at those rates and say, well, this isn't function, because with alcohol and drug addiction, it's a really, like you said, it's a really high recidivism rate. And so it's less important of how often they aren't successful as opposed to it's more important that they keep coming in for help. I think that's kind of how they look at it.
We'd still be bleeding people for tuberculosis, if that is the attitude. The other areas of medicine.
We're bringing back leeches then.
Yeah.
Well, thanks so much. Okay.
All right.
Next.
All right, so the last topic on the agenda, so this is, Meridian is we had them do what is called a probe and educate review. So they took some of our claims and looked at it to look at our overall claim from admission all the way through to see how we're doing and what our rate of errors are. And this is a summary for Wildflower Court because we have recently started billing on Wildflower Court and we want to make sure that our process is efficient and we are billing correctly. And so this is the review summary that we had on Wildflower Court. And now we are realizing that we need to do some changes in our processes over there.
So I'm confused as to what this letter was. When I first looked at it, I didn't understand that this is an entity that we engage.
Yes.
It said CMS on the page and I thought, oh,
Yeah, so we engaged with this because this is new to us. So we are, our billing department is learning billing. Our medical records is learning medical records. So we are engaging with them because we want to ensure that our billing and our medical records are done correctly, plus our case management. So we wanted to do a look back before we are starting to really ramp up our billing. And this is what they have given us back, and we are working with them to provide direction and education on it. So what we've done now is Rachel Stark with our medical records department is actually very engaged over there and is looking at every admission from start to finish proactively at the beginning. Because what happens, as you can see, is a lot of times the admissions are delayed a day or two. So the physician will do all the paperwork and then the admission might be delayed a day. And then the paperwork needs to be re-signed. And we're finding that we have some processes that are actually causing our billing to be denied. So now we have to look at our processes over there, because if we continue moving forward the way we are, we're going to have some substantial issues. So this is actually good that we're doing this proactively. And this is going to be part of our internal audits moving forward that we're tracking. Because it's a 61 bed facility that doesn't have a great turnover. So we should be able to do 100% audits on every admission coming in there, compared to like the turn and burn of a hospital.
A few a month.
Right.
essentially. And it looks like we have work to do.
It does. We definitely have work to do, and there's no reason why we shouldn't be able to catch it. The other thing that they're looking at is right now their process is 100% a paper process, where they're actually mailing papers out to the doctor to have them sign it and send it back either via mail or faxing, which rather than using like a DocuSign or other more modern ways of getting information. So when you have a holdup on an admission and that, you can get paperwork signed more readily over there. So there's definitely some processes that need to be done quicker. So this is one that we'll probably be doing monthly audits on Wildflower Court of every single admission that comes through.
With this, I also sent Rachel and Tammy, our HR and PFS director, through special lead training for long-term care
Yeah.
building. And then in addition to that, we've placed Tammy over in that building 2 days a week, so she can kind of understand the process and be more hands-on in the building process.
Yeah.
So you guys are aware.
And I think I think you're having Rachel's team go, have all of them have training in.
Yeah, they're all trained, so we have class coverage across the board.
I must say, I mean, that's very beneficial to able to, utilize the much more substantial resources of our hospital to help with the billing over there. So their bottom line was reasonable even without us, so it should be better. Right?
It should be ideal.
Yeah. I think now that we have good staffing and we can keep the beds filled, because that was their issue too, is I don't think they had enough staffing to keep their beds filled. I think now that we're able to keep the beds filled and provide the support for their fixed costs, like their HIM and their billing, it'll be run a lot more efficiently. And be able to look at things like that. In their HIM, they have stacks of paper. The other part is they don't use Meditech, they use a system called Matrix Care, which is it's actually a very robust system for long-term care. It's actually due to be upgraded. It's a cloud-based version and it's due to be updated this winter or spring. And they actually have some good upgrades in the system. And it's actually less expensive than Meditech. That will help with the billing and the processing. So
Less labor intensive.
yeah, that I think will help with their processes moving forward. That'll help it be a little more streamlined. So I think Tammy was in on that call.
I have a question that's completely off topic, but maybe you can indulge me anyway. So I noticed the letter was directed to Kim. Is there any thought about when Kim will be replaced?
We've opened up that recruitment process, and so we're kind of in the midst of it. Kim's agreed.
We have a meeting with her today to see if we can have her stay on even as in a remote option, just so that she can still have that nursing administrator license.
Yeah.
She's willing to stay on and do that, but her Chad and I will sit down today and determine what that looks like. She can still provide some support remotely.
You say she has agreed to stay?
She has in some capacity for remote. So we just have to figure out what the details looks like.
Because when Kim was coming in, Phil Hofstadter held out her license to start.
Yeah.
I didn't know she was leaving.
Yeah, we had 2 reservations my first day at CEF. Had my IS director and Kim Stout gave resignation to Kim. So I think that one was walking out of my office and the other one was walking into hers.
Why? Is it just social or?
So Kim Stout is a sub-family. There's some family that needs some medical support. So that's why she's going. She was only slated to be here till August anyway, next year. But then something happened back home and she needs to go help provide some medical support.
The information system's been a little bit of a problem. So that is, do we have anybody from the old days in our?
We've had people reach out. We're waiting Cliff to come in and help a little bit to kind of bridge the gap into new management.
What's the longest employee in information?
Max, we have
Max.
Pete.
Oh, yeah. It's 10 years, but 5 to 10 years.
Max has been there as, gosh,
I was gonna say, he's been there longer than I have been.
yeah.
More than 13 at least.
Yeah, Max has been here as long as I've been here. Pete's been here a long time.
Oh,
I mean,
yeah.
Max served as interim a few times too.
Yeah,
Okay.
yeah. And James has been here probably 10 years now.
Close.
Yeah.
But from a director standpoint, what's the longest tenured director we've had? Scott Shelley, probably.
Martha,
Martha, maybe?
Martha was there for a while. Yeah.
It's right now, it's,
Chris Letterman.
yeah, Chris. He's only been here
Year
a
and a
year.
half.
But he's been in town for a long time. And so he must be moving somewhere else in town, I'm guessing. No.
We had future plans. I think the changes in the organizational design. He didn't agree with some of the changes we made, so we left it to move on. But we've been actively engaged with staff since that happened though. So we're working on it.
Well, thanks so much. I think that brings us to the end of our business. We're not going to have executive session. That brings us to committee comments and questions. I don't have any. I appreciate all my questions were, or I know all my questions were answered.
Yeah.
Any comments from staff?
Who else is on this committee?
Yeah, okay. She couldn't be here. And then it was a mistake on my part that Kenny had told me he couldn't be here at this time. We shouldn't have them early. Shouldn't have these meetings.
Did have one comment that Rhonda didn't bring up, but the 42 citations was out of a total of 1,403. So just to kind of give us some context about how well.
Potential
citations,
Yeah.
yeah.
Point out something.
Yeah.
Okay, thanks so much. Guess we're adjourned.
And then I'm just going to answer a couple of texts and because I'm still working. So, and then we're going to have a meeting for